Hi, I'm Lisa. I'm a research associate based at the University of Manchester. I'm presenting this work on behalf of myself and my co-authors that are listed on the slide. Our presentation is focused on the challenge of integrating signposting into general practice, specifically looking at the perceptions of people involved in care navigation and social prescribing services. To first explain the wider background, we know that demand on primary care is rising. That's because not only are we living for longer, but we're also living with increasingly complex health needs. In addition, there is a national shortage of GPs, and so this all fuels the challenge of providing enough capacity to meet the demand for primary care. This has led to a national policy focus in England to address workforce issues in primary care. And alongside making efforts to increase the number of GPs, a key priority has been to integrate new roles into general practice to redistribute workload. And this was first outlined in the GP Forward View in 2016. And more recently, the NHS Long-Term Plan and the GP Contract 5-Year Framework, both published in 2019, have set out the intention to create an additional 20,000 non-GP roles in general practice over the next 5 years. Funding is being provided through the Additional Roles Reimbursement Scheme to primary care networks to recruit staff. To move on to talk about the care navigation role, it's a role that's an enhanced role usually undertaken by GP receptionists, and it's based on active signposting, which aims at the first point of contact to signpost patients to the right professionals at the right time. The care navigation role was included in the General Practice Forward View, and with it there was a £45 million fund made available to CCGs to train receptionists and clerical staff to undertake enhanced roles, of which one of them was active signposting. So the care navigation role was estimated to free up 5% of GP consultations, to make the most appropriate use of the non-GP workforce, and to increase receptionist job satisfaction, as well as making it easier for patients who required a GP appointment to access one. The evidence to support the effectiveness of the care navigation role is limited, and more robust evidence is needed to see how the role impacts on the wider primary care system. To move on to the social prescribing link worker role, it's important to say that there's no agreed definition of social prescribing, and different models have been adopted across different areas. Some assert that care navigation is a basic form of social prescribing. In addition, the link worker roles often have different titles in different areas. Some call them care navigators, some call them community navigators or community connectors, for example. For the purposes of this paper, we define the social prescribing link worker role as the referral of patients with social, emotional or practical needs to non-clinical services to provide holistic community-based support through shared decision making, and it's based on what matters to the person. The NHS Long-Term Plan committed to employing 1,000 new social prescribing link worker roles by 2020 to 21, and 100% of funding for these roles was available to primary care networks. The evidence to support the social prescribing link worker role is mixed as well. So there are pockets of evidence that social prescribing can lead to a range of positive health and wellbeing outcomes, but a systematic review conducted by Bickerdike and others in 2017 concluded that there was a lack of robust quality evidence to show effectiveness of social prescribing. And this systematic review was recently updated by Public Health England, and it reached the same conclusions. So, while there's an enthusiasm and a policy drive to integrate non-GP roles into general practice, little is known about how non-GP roles are planned and operationalised into primary care, and that's the focus of our study. The data that we report on in this presentation form part of a wider study that explored the integration of non-GP roles in one region in the UK. And that was conducted to investigate the operational issues faced in implementing these new roles into general practice. The focus of this presentation is to report data from the interviews we conducted with people involved in care navigation and social prescribing roles to understand the challenges of integrating signposting into general practice. And we recruited 33 respondents to take part in 18 semi-structured interviews and 1 focus group. We purposefully recruited respondents from a variety of roles, such as service leads, role holders, so receptionists undertaking care navigation, and people in link worker roles. And we also interviewed some host GP practice staff, such as practice managers. We undertook thematic analysis and used the constant comparative method to identify similarities and differences within and across the data in order to develop the themes that we present. 3 themes are presented around the challenges of integrating signposting into general practice in care navigation and link worker roles. And the challenges are common between the roles, but they play out differently within each role. The first challenge relates to role perception. Signposting was made challenging by the way both roles were perceived by staff and by patients. For the care navigation role, care navigation was explained as a way to enable patients to be seen by the right professional at the right time, but respondents also acknowledged that a key driver was to save GPs time. However, in some cases, respondents reported that care navigation role was perceived by patients to merely signpost them away from the GP. And when patients resisted attempts to be signposted away from a GP appointment, this could lead to challenging and uncomfortable interactions for receptionists who were carrying out care navigation. This highlights the potential conflict between the 2 goals of freeing up GP time and addressing patient needs, and whether these 2 goals are compatible. For social prescribing link workers, much more emphasis was placed on this as being a way to improve patient care, to address wider social and psychological needs of patients, and there was a strong focus on the role being person-centred and holistic in nature. And it was also considered to be much more than signposting people to community assets. A significant part of the role was in establishing trusting relationships with the clients to enable change. However, a lack of role clarity among staff meant that social prescribing link workers received referrals that they were neither intended nor equipped to manage. So in effect, patients were inappropriately signposted to them. The main inappropriate referrals received were patients who were in mental health crisis, though this became less of an issue as social prescribing services became more established. The second challenge relates to role preparedness, and signposting was made challenging by complications around role remit and training for both roles. Some receptionists considered the upskilling of their role as an opportunity for career development. However, others described how they felt unprepared for the care navigation role, and they saw signposting as a form of triage and didn't feel that it was a role suited to a non-clinician. And this led to concerns about patient safety. Some described how they'd not been given any formal training to take on the enhanced role, and some had undertaken care navigation training, which had helped them to feel more confident in carrying out care navigation, but training was often undertaken several months after starting to do the role. As for the social prescribing link worker role, it was a relatively new role, and so role holders often came from a variety of different backgrounds. So they might have previously worked in housing or debt management or health coaching. And that meant that they had different training and different skills. And while this was highlighted as a positive in having different expertise across the team, there were concerns that it affected the consistency of offer across areas, and that might affect the way that signposting and other aspects of the job were done. In light of this, there were attempts to create competency frameworks in some areas to standardise their offer. Challenge 3 relates to the integration and coordination of roles. The lack of planning and coordination across services could impair signposting and therefore the success of both roles. And the success of these roles was reliant on the interrelationship between wider services and systems. In the care navigation role, a lack of planning and coordination between primary care and other parts of the health and social care system saw instances of signposting patients to overloaded services that they didn't have the capacity to accept. And this led to a lack of patient trust in the receptionist and created dissatisfaction for role holders. For social prescribing link workers, successful schemes were considered those with strong relationships between primary care and voluntary sector, and concerns were raised about how the primary care-based role, now supported by funding to PCNs, would operate alongside the more long-standing voluntary sector link worker role already in the community, and crucially, whether the link worker role, including the signposting aspect, could become narrowly clinically focused, so less holistic and less person-centred as the role was originally intended. Our study provides learning opportunities for implementation of signposting in general practice, and we think this is one of the first studies to specifically look at the issue of how signposting is being operationalised in general practice and the issues that this raises. This study has highlighted the need for communication and engagement between stakeholders to make sure that they understand the role of signposting to ensure uptake of the service and appropriate referrals. People undertaking care navigation roles and link worker roles need the appropriate skills and resources to carry out the role in order for them to feel confident and competent, but also to ensure consistency of offer across areas. And finally, to support the role of signposting in primary care, there's also a need for collaborative commissioning and partnership working and continued support for community groups, not only to ensure that there is the capacity to signpost patients away from general practice, but also to make sure that the services continue to be person-centred. Thank you for listening.